There are drugs in your anesthesia cart that you give every single day. Antibiotics before incision, neuromuscular blockers for intubation, latex gloves, routine, familiar, safe, until they aren't. Intraoperative anaphylaxis is one of the most terrifying events in the operating room because it looks like something else first. Hypotension you attribute to anesthesia. Bronchospasm you think is the airway. A rash hidden under the surgical drape. By the time you recognize it, the clock has already been running. I'm Anesthesia Buddy, and today we're talking about intraoperative anaphylaxis. Let's get into it. It's a routine case. 47-year-old female. Healthy. No known drug allergies. Coming in for an elective laparoscopic cholecystectomy. You induce smoothly. Propofol, fentanyl, rocuronium. Intubation goes perfectly. Surgeon requests a Vaseline before incision. You push it. Standard, routine. You've done it 1,000 times. 7 minutes later, blood pressure, 82/48, was 128/76 at induction. You give a phenylephrine bolus. BP comes up briefly, then drops again, 58/32. Heart rate climbing, 118, was 68. You increase your volatile agent slightly. Wait, that would drop pressure further. You turn it down. Airway pressure alarm goes off. Peak inspiratory pressure climbing. Breath sounds. Bilateral wheeze. You suction the ETT. Nothing. Surgeon says, "There's some swelling here. Is that normal?" You lean over the drape. Erythema spreading across the chest. Urticaria forming at the IV site. And suddenly, everything that looked like separate problems becomes one diagnosis. This is not hypotension from anesthesia. This is not bronchospasm from the airway. This is anaphylaxis. And it started 7 minutes ago. Intraoperative anaphylaxis, an acute, severe, systemic hypersensitivity reaction that occurs during anesthesia. Incidence, roughly 1 in 10,000 to 1 in 20,000 anesthetics. Mortality, up to 10% even with treatment. Here's what makes it so dangerous in the OR specifically. The patient is draped. You can't see the skin. They're intubated. They can't tell you they feel wrong. They're already hypotensive from anesthesia. The bronchospasm gets blamed on the airway. By the time you recognize it, you've often lost precious minutes. The mechanism: type 1 hypersensitivity reaction. IgE mediated, or in some cases, non-IgE mediated direct mast cell activation. Massive release of histamine, tryptase, prostaglandins, leukotrienes from mast cells and basophils. What this does to your patient: vasodilation, massive. Capillary leak, fluid pouring out of the vasculature. Cardiovascular collapse, bronchospasm, urticaria, angioedema, erythema. The most common triggers in the OR. Know these cold. Number 1, neuromuscular blocking agents. Rocuronium and succinylcholine are the most common culprits, responsible for up to 60% of intraoperative anaphylaxis cases. Number 2, antibiotics. Cephalosporins and penicillins especially. Number 3, latex. Less common now with latex-free ORs, but still a significant trigger, especially in patients with repeated latex exposure, spina bifida patients, healthcare workers. Number 4, chlorhexidine, often overlooked, used for skin prep, catheters, wound irrigation, can cause severe anaphylaxis. Number 5, colloids, dyes, opioids, protamine, and non-steroidal anti-inflammatory drugs. The classic triad you're looking for: cardiovascular collapse, sudden unexplained hypotension that doesn't respond to pressors, bronchospasm, rising airway pressures, wheeze, difficulty ventilating, cutaneous signs, erythema, urticaria, angioedema. But remember, under the drape, you may not see these until it's already severe. You don't need all 3 to make the diagnosis. Cardiovascular collapse alone during anesthesia should make you think anaphylaxis until proven otherwise. You have identified anaphylaxis. Here is exactly what you do, right now, in order. Step 1. Call for help immediately. This is not a one-person crisis. Get your attending, get the team, get everyone in that room. Step 2. Stop the trigger. Identify what you gave in the last 10 to 15 minutes. Stop any infusions that could be causative. Remove latex products from the field. Tell the surgeon to stop using the chlorhexidine irrigation. Step 3. Epinephrine. This is your primary treatment. This is not optional. This is not a last resort. Epinephrine first. Dose for cardiovascular collapse. Epinephrine 10 to 100 micrograms intravenous bolus. Titrate to effect. Repeat as needed. If refractory, start an epinephrine infusion. 0.05 to 0.1 micrograms per kilogram per minute. Titrate up. Why epinephrine? Alpha 1, vasoconstriction, raises your BP. Beta 1, increases heart rate and contractility. Beta 2, bronchodilation. Stabilizes mast cells, stops further mediator release. Epinephrine does everything you need in one drug. Use it early, use it aggressively. Do not delay epinephrine for antihistamines or steroids. That is a common, deadly mistake. Step 4. Intravenous fluid resuscitation. Large bore intravenous access if not already present. Rapid bolus. 1 to 2 liters of crystalloid. These patients are losing fluid out of their vasculature rapidly. They need volume. Give it fast. Step 5. Airway management. If not already intubated, intubate now. Angioedema can close the airway fast. If already intubated, manage the bronchospasm. Increase FiO2 to 100%. Manually ventilate if needed. Salbutamol, albuterol, via the breathing circuit for bronchospasm. Step 6. Secondary treatments. These come after epinephrine and fluids, not instead of them. Antihistamines. Diphenhydramine 25 to 50 milligrams intravenous. H2 blocker, ranitidine or famotidine. These help with urticaria, but do nothing for cardiovascular collapse. Corticosteroids. Hydrocortisone 200 milligrams intravenous, or methylprednisolone 1 milligram per kilogram. These help prevent biphasic reactions, but take hours to work. Do not rely on them acutely. Step 7. If refractory to epinephrine, consider vasopressin, 2 to 4 units intravenous bolus. Norepinephrine infusion. Methylene blue has been used in refractory cases. Glucagon, 1 to 2 milligrams intravenous if the patient is on beta blockers. Beta blockers blunt the epinephrine response, and glucagon bypasses this. Step 8. Send a serum tryptase. Drawn at time of reaction, 1 hour after, and 24 hours after for baseline. Elevated tryptase confirms mast cell activation and is essential for allergy workup post-reaction. Step 9. Document everything. Time of reaction, drugs given, timing. The allergist needs this information for skin testing and future anesthetic planning. Step 10. ICU admission. Biphasic anaphylaxis occurs in up to 20% of cases, a second wave of anaphylaxis hours after the initial reaction. This patient needs monitoring for a minimum of 24 hours. The board questions hiding in this crisis. Question 1. What is the first-line treatment for intraoperative anaphylaxis? Not diphenhydramine, not steroids, not fluids. Epinephrine. Always epinephrine first. That answer will not change. Question 2. What confirms the diagnosis of anaphylaxis after the event? Serum tryptase. Elevated tryptase confirms mast cell degranulation. Draw it at time of reaction, 1 hour after, and 24 hours for baseline. Question 3. What is a biphasic reaction? A second wave of anaphylaxis occurring 1 to 72 hours after the initial event, despite apparent resolution. Occurs in up to 20% of cases. This is why ICU admission is mandatory. Question 4. Which patient population is at highest risk for latex anaphylaxis? Spina bifida patients, due to repeated surgical latex exposure from birth. Always use a latex-free environment for these patients. Question 5. What do you give for anaphylaxis in a patient on beta blockers who is not responding to epinephrine? Glucagon, 1 to 2 milligrams intravenous. Beta blockers blunt the cardiovascular response to epinephrine. Glucagon bypasses the beta receptor entirely. Intraoperative anaphylaxis, hidden under the drape, masked by anesthesia. Deadly if you hesitate. Your rapid-fire review before you go. Most common trigger, neuromuscular blocking agents, up to 60% of cases. First-line treatment, epinephrine. Always, immediately. Do not delay for antihistamines. Dose, 10 to 100 micrograms intravenous bolus. Titrate to effect. Confirm the diagnosis. Serum tryptase drawn at time of reaction, 1 hour after, 24 hours for baseline. Biphasic reaction, occurs in up to 20% of cases. Mandatory ICU monitoring for 24 hours. Beta blocker patient not responding. Glucagon 1 to 2 milligrams intravenously. And the lesson behind all of it. When your patient is draped and intubated and something feels wrong, think anaphylaxis early, not after you've exhausted every other explanation. Early epinephrine saves lives. Late epinephrine doesn't. If this helped you, share it with one person studying for boards right now. And if you want to be ready for the next crisis before it walks through that OR door, subscribe to Anesthesia Buddy. The best time to learn this is before you need it. I'm Anesthesia Buddy. Stay sharp. See you in the next one.